I was recruited into this nice collaboration with people from Reykjavik and from Ancona to put up a model about that can describe remodeling and predict remodeling in patients undergoing total hip arthroplasty. And those are some early stage results from the first, let's say, the first run, the first test of the model on the data. So let's start here with a little background. Okay, so we are studying people undergoing total hip arthroplasty surgery. That is one of the most common treatments for osteoarthritis. And it consists in the replacement of the hip joint, basically, by prosthetics. And it comes in two main types of operation. It is the cemented and the uncemented prosthesis. And the aim is that of reducing pain in patients with osteoarthritis, obviously. The idea is that the type of implant, so the cemented or the uncemented prosthesis, with other factors like BMI, sex, age, and medical history, can influence how bone is remodeled from the operation going on towards the ears. So to tackle this problem, we focused mainly on measures that are extracted from CT scans, so CT imaging, of the Gruen zones, which is basically a map of the different zones of the femur that serve as interfaces between the bone and the prosthesis. And also we use some muscle density in terms of bone mineral density that indicates it's an indicator of the status of bone health. And then we also integrated some muscle density parameter of the rectus femoris, which is a muscle that intersect the muscle of the section of the quadriceps that intercept the hip and the knee joints. Okay, so this is what these measurements from these two from these two regions, from these two tissues, are what we are using to feed our model for predictions. The aim is obviously the prediction and description, with a big emphasis on and description, of changes in bone mineral density and muscle density over the years after the intervention. And the ultimate goal is that of creating a tool that is capable of providing a good decision-making tool for surgery. So to assess which implant is better for a certain class, a certain type of patient. Emphasis on description because interpretable machine learning models, in my opinion, are what can make us step from machine learning for the sake of it to personalized and stratified medicine. Okay, and then let's see how it translates to the early findings that we are presenting today. So a little summary on the workflow. Obviously, we have the data acquisition. Phase. Sorry, I have to put on my glasses. Forgot. Which is the data collection and all the CT scans from the patient. That we have. Then we have some image processing, so removal of artifacts, normalization, and things like that, and also obviously segmentation of the Gruen zones in the femurs. Then we have the dataset construction, and we'll see in a while how our dataset is composed. And obviously, the prediction and the description through some machine learning approaches. Okay, so our dataset is basically split into these three types of information contained in it. There are some clinical data, some metadata about the patient that will help us study which factor that we cannot directly observe for the images influences the bone remodeling. And then we have the imaging data, Gruen zone from 1 to 7, a BMD of the total bone, and the muscle density of the rectus femoris. The clinical data all comes from the Landspital in Reykjavik, and all the segmentation and image processing was done using Mimics software. Okay, so let's get to how the data are split in our data set. We have a total of 98 patients. We have 86 unilateral surgery. That means that the operation was done only for one leg, and 2 bilateral surgery. We have quite a span of age, because there are patients as young as 19 to patients as old as 76, even if, as you can see here, the majority of patients were shifted toward higher ranges of ages. We have 13 patients lacking BMI information, and so here is a little summary. We are quite balanced as far as sex of the patient is concerned. Interestingly enough, we have a very dishomogeneous sex distribution in the cemented intervention, and as I understood, and my colleagues can correct me if I'm wrong, that depends on the fact that females had an age distribution that tended toward older ages, so were more likely to get a cemented prosthesis. And now for the machine learning part of the talk. Let's see how the framework works. After some optimization of the dataset, outliers detection, data cleaning, etc., we split it in the dataset into the 1-year follow-up and the 6-year follow-up to train 2 separate models, also to study how the remodeling of the bones changes, if there are changes between 1 and 6 years. We have 62 controls, so legs without unoperated legs, and 58 operations. And then we have 29 in the 6-year dataset. We have 29 control and 39 operations. So we have a bit less samples in the 6-year follow-up. The framework. Now, this is a dataset that is a very well-posed problem for principal component analysis, which is basically a dimensionality reduction of our problem, because we have a very good ratio between features and samples. We have 8 features for quite a good number of patients. So we can guess that the composition of the covariance matrix of the dataset will give us a way to explore the variability, the differences between patients contained in the dataset in all its complexity. And we can also use this phase to reduce the dimensionality of the problem. Using PCA, we can study the correlation between the features, how the correlation, not also single feature effect, but also correlation between features evolves during the year, as we can see. We'll see briefly. And studying the topology of the latent spaces can help us identify interclass variability, so operated leg, unoperated legs, or the 3-class problem, operated legs, cemented and uncemented, but also intraclass variability, that is the variability that depends on unobserved factors. Okay, and then we trained a self-optimizing feature selector and self-optimizing random forest. Using the Bruta feature selection, which is a very cool feature selection that, for those of you more interested in machine learning, we can talk about. And then we compare the topological results from the covariance, the composition of the covariance matrix using PCA, and then the result from the random forest to try to draw some etiological conclusions. So. Let's try to navigate these graphs for those who are not familiar with PCA. Basically, we are trying to project all the variability in a data in a lower dimensional space, and we do this by diagonalizing the covariance matrix, for those of you that are familiar with linear algebra. But what does it mean? It means that I want to find a way to summarize everything that is contained in my dataset and see how much of this variability is explained, in this case, by the fact that the leg we are looking at through the features is operated or unoperated. And as you can see from the pair plot here, if we scatter all the each point here is a patient in the data set, okay, represented in a 2-dimensional space. If we scatter all the patient and try to color them according, in blue, you have the control, and in red, in orange, you have the operation, you can see that the first 2 PC components and the estimation of the marginal probability function that basically tells us how much of the variability contained in that latent component is associated to class difference. Okay, so we are seeing that PC0 here and PC1 in these two latent components, the class are somewhat already separated. This here is a B-plot, and this comment here will help you to navigate through the graphs if you can read them. In this graph here, the points, each one is a patient. The nearer, the more similar each other. And then we have these vectors here that represent how the original features relates to these latent components. Okay? This basically means that in this space, every linear classifier I'm going to train will draw a line here and perfectly separates operates and unoperated legs. Okay? And this space also tells us that there are this group of features that are very correlated, very parallel to this latent component, and that means that the variability of these features explains the variance summarized by this component here, which is related to class difference and are basically telling us which are the features that contribute to class separation. Okay, this is how we read this graph. Now, let's try to compare this result with a more general classifier because PCA is an inherently linear method. So, let's try to see if we train a random forest with a lot of cool things like self-optimization and all the modern machine learning things. I put them all there to get a very robust and state-of-art model. Okay. We have a feature selection that tells us which are in advance the features that contain the highest information. It prunes some of the completely uninformative features, and then through classification we get an array containing scores attributed to the feature that must sum to 1. So basically, as far as the two classes classification problem in 1 year is concerned, we have a very high classification score. Everything is cross-validated and also cross-validated to simulate prediction. We have a blind holdout of the 20% of the data set. So complete after cross-validation. So this is a good measure of how our model seeing new data can perform. This basically, the random forest converges to a tree with a single node that splits the entire data set between operated leg and unoperated leg just by looking at the increase in bone mineral density in Gruen zone 3. So we already have quite a result. We are able to see that all the variation, all the modeling after 1 year is focused in Gruen zone 3. Let's try to do the same. I'm going to be much quicker now that we understood how to read this graph. Let's try to do the same with the 6-year data set. As you can see, we have a little less sample. We have the class that are their separation is as good as the previous one, but we have some changes of how the separation of the class are defined. We have a change in correlation about this Gruen zone here, and we can see from this vector that Gruen zone 7 starts to get a high importance in defining the operated class. Also, as you can see, this is also an effect of the smaller sample size, but we have, after 6 years, an intra-class variance that is highly augmented. It means that unobserved factor after 6 years induce a detectable change. Okay, so the random forest model tells exactly the same things that the PCA tells us. We have the Gruen zone 2 and 3 that are still important, but we have most of the information that separates operated from unoperated legs in Gruen zone 7. So we can conclude that after 6 years, the bone remodeling diffuses also to Gruen zone 7, with Gruen zone 2 and 3 being involved. And the changes in correlation between these important Gruen zones basically can reflect how the bone remodeling changes through the year. Now, let's look at a final partition of the dataset. So, operated, unoperated, and control and uncemented and cemented features. The PCA space is the same. We are just coloring the points, adding this class. And what we see is that even after 1 year, all the cemented processes tend to strive on higher scores on PC 0. And that means striving toward higher values of this group of features here that from the tree we learned that are guided by green zone tree. Okay? And this is basically what, once again, the random forest trained on the tree class problem tells us. After 1 year, the type of operation are somewhat distinguished, and the entity of this distinction is given by the performance of the decision trees. The important features are green zone 2, 3, and 7. And we have a little cluster, if we get back here, that are also defined by fine in green zone 6, between here, especially from the cemented class. Let's do the same problem for the 6-year data set, and we see that this difference starts to drift in a very, very blatant way toward high scores of PCA. So that basically tells us that green zones are variances in green zones are defining the entity of changes in the green zones is defining the entity of the operation. And that this is the same conclusion that we draw from alike in the previous slide. And looking, I'm done, and looking quantitatively of how this difference impacts effectively, we can see that green zone 3, after 1 year and after 6 years, you present significantly, statistically significant different distribution that tells us that cemented processes tend to emphasize bone mineral density, bone mineral growth, while uncemented processes moves away from control, but it sort of stalls after 1 year. And that we can say the same for green zone 7. So we already have drawn some nice conclusions. The frame of the conclusions, the general conclusion are that given this general trend and these features that we got as important, the framework is basically promising, and all the tools that need to describe the complete description are already there. We identified and reduced the dimensionality of the problem as far as general trends are concerned to 2 features. We can see that operational characters are raised in by the type of operation is related to the entity of the shift in green zone 3 and 7. And this poses the basis for a big what's next. So the study of the impact of the covariates for the intraclass variance explanation that moves us towards stratified medicine. The integration with images and morphometric feature from high-resolution images from synchrotron studies toward this ultimate goal that this is that of helping the decision making. Okay, I'm done. I hope I wasn't too long. Really sorry.
Thank you, Carlo.